very usual to correct the patients with this kind of device. So I hope that you will enjoy the presentation, and that I can bring something interesting for you. This study, as Dr. Pratali said, was published in the Bone and Joint Journal. It's a study that we performed in New York when I was in New York with Dr. Virginie Lafage in the Hospital for Special Surgery, and we performed a comparison of pedicle screw instrumentation and sublaminar bends. So let's go a little bit deeper into this. So as you all know, adolescent idiopathic scoliosis is a three-dimensional deformity. Three-dimensional meaning that there is often a deformity in the sagittal plane with quite frequently flattening of the thoracic spine, especially in thoracic curvatures, with patients with a hypokyphosis. The consequences of this hypokyphosis is obviously the flattening of the adjacent curvatures, as the curvatures of the spine are supposed to be proportional between each other. So if you have a flattening of the thoracic area, you will have a decrease of the lumbar lordosis, and frequently a cervical kyphosis associated with this deformity. So the consequences of the sagittal plane deformity is not clear, but the thing that we know for sure is that in adult population, the sagittal malalignment is the parameter that is the most that have the most impact on the quality of life. So it's probably very important to correct the sagittal deformity as well. So when you manage adolescent idiopathic scoliosis, your surgical correction should aim for 1, coronal deformity correction, and 2, sagittal alignment restoration. In order to shoot this goal, you have numerous surgical techniques that have been described, and different implants that can be used for that. You have the all pedicle screw instrumentation that is the gold standard, as it's used very widely all over the world because of its great ability to provide a good coronal reduction. But some concerns have been raised about the all pedicle screw instrumentation, as it's very likely that it has a lordotic effect. And when you manage patients with thoracic hypokyphosis, you will it's likely that you will worsen the hypokyphosis. In 2009, sublaminar bends have been introduced by Mazda et al., who was the former chief of department of pediatric orthopedics in Paris. And the principle of these implants are that by putting sublaminar bends on the spine, you will pull the spine backward and towards the middle line. So it's called the posterior medial translation, and it's supposed to have a kyphotic effect. But so far, there was no comparison that was available in the literature between the gold standard, so the all pedicle screw instrumentation, and the hybrid instrumentation using sublaminar bends. So it was our objective to compare the radiographic results between hybrid instrumentation and all pedicle screw instrumentation in patients with main thoracic curvatures. So we performed a retrospective cohort study, including patients operated on in 2 different centers, in Marseille in France and in the HSS in New York in the United States. We included patients with adolescent idiopathic scoliosis, Lanky 1 and Lanky 2, meaning that they had a main curvature in the thoracic area, 1 or 2 curves. And patients were divided into 2 groups according to the technique that was used to reduce the deformity. In the hybrid group, so patients were operated on as follow. We had proximal and distal anchors in the lumbar and in the upper thoracic area. We put the 2 rods in place with 2 transverse connectors. So we obtain a rigid frame, and from there we do a gradual tensioning of the bends, allowing for the spine to be pulled backward and towards the midline. It's the posterior medial translation. in the old pedicle screws, so it's the gold standard, so everyone knows it. Pedicle screws were inserted at every level, and the cantilever technique was used. We evaluated our patients based on different radiographic parameters, preoperatively, postoperatively, and at 2-year follow-up. And for the statistical analysis, we believe that it was possible to have a much more statistical power by matching the cohorts according to preoperative parameters. And we did a global analysis, including all the patients, and then a stratification according to the preoperative thoracic kyphosis. So after, at final, we were able to collect the data from 151 patients. And after matching, 45 patients remained into each group. By design, they were not different according to the following parameters. And at immediate post-operative, you can see that in terms of coronal correction, it was quite the same between the two groups, even if the absolute value of the Cobb angle was a little bit lower in pedicle screw instrumentations. You can see that the percentage of correction was not statistically different between the two groups. On the other hand, in terms of thoracic kyphosis, you can see that it was largely better restored in the sublaminar bends patients, with at the end a thoracic kyphosis of 28 degrees and a gain of kyphosis of 2 degrees, whereas there was a loss of thoracic kyphosis in the pedicle screw patients. At 2-year follow-up, there was a greater loss of coronal correction in sublaminar bends patients, with a 4 degrees loss of correction in the coronal plane, whereas there were only 2 degrees of loss of correction in the pedicle screw group. That is probably due to the variation of measurement. In terms of thoracic kyphosis, it was once again largely greater in sublaminar bends patients. Now let's go a little bit deeper into analysis, and let's have a look to the stratification analysis results. You can see that when the preoperative TK was normal, or when there was an hyperkyphosis preoperatively, the results were quite comparable. But when it comes to hypokyphotic patients preoperatively, you can see that the results were largely better, once again, with the sublaminar bends, with a thoracic kyphosis ranging from 10 degrees preoperatively to 28 degrees postoperatively with the bends, and 14 degrees with the pedicle screws. So I will not go too much further into lit review, because I think Dr. Dyer will take this, will manage this after me. But when looking quickly at the literature, you can see that in terms of coronal correction, it's quite the same between the sublaminar bends and the pedicle screws. And in our study, the results are quite in line, because we had the same coronal correction at immediate post-operative, but with a greater loss of correction at 2 years. So it can be considered as a flaw of the sublaminar bends, but it's only 4 degrees. So it's, even if it's statistically significant, I'm not sure that it's really clinically relevant. It's maybe a loss of bends tensioning while the fusion is being acquired. So during the 3 first months, it's in line with the results that we previously published with the Marseille team, where we found a 3-degree loss of correction at 6 months, but with no further change after the 6 months follow-up is passed. In terms of sagittal correction, it was, I mean, in the literature, the bends have the reputation of allowing for a great increase of thoracic kyphosis, whereas quite all the studies with pedicle screws have shown a decrease of kyphosis. That's in line with what we found in our study, and it was especially true in hypokyphotic patients. Why is that? Well, it's because the philosophy of reduction is totally different between the two kind of implants. When you use the bends, you attach your vertebrae to the rod, and by tensioning the bends, you have the ability to pull your spine backward leading to an increase of kyphosis. Whereas with the cantilever technique, it's not particularly the pedicle screws, it's maybe just the technique of reduction, but you apply great constraints over the rods and the spine, and you have it leads to the rod being pushed towards the spine, and then it's more difficult to increase kyphosis by doing like this. So in conclusion, this is the first study comparing the sublaminar bends to the pedicle screw instrumentations. These are different techniques with different advantages, and they may be used in different patients. The pedicle screws provide a better coronal correction at 2-year follow-up. That's what we've seen, even if the coronal correction was very good with the bends as well. But the bends have the ability to provide a better sagittal alignment restoration with really a greater increase of kyphosis. The first question that came to my mind when reading the results of our study is that maybe it's not possible to have a simultaneous correction of both coronal and sagittal planes. And I still don't have the answer, but the real question that we may ask is it necessary to have a 0-degree residual cob with a flat back, or is it better to have maybe a 15 or 20 degrees residual cob angle in the coronal plane, but with a good restoration of the thoracic kyphosis? As I repeat, I don't have the answer to that, but it's maybe a question that we may ask. So from the results of our study, we can end with this kind of recommendation. According to the preoperative TK, you can choose the different techniques. If you have hyperkyphosis, it's probably better to use pedicle screw instrumentation in order to help to decrease kyphosis, because that's what you cite when you manage hyperkyphotic patients. But on the other hand, when you have hypokyphotic patients, it's probably smarter to use sublaminar bends in order to increase your kyphosis and to restore a better sagittal profile. When the kyphosis preoperatively is normal, you can use both pedicle screw instrumentation or sublaminar bends instrumentation, but you have to be to take care of not ending with a hypokyphosis postoperatively when using pedicle screw instrumentations. Thank you.
Okay, very good, very good. Excellent job.
Thank you.
So I think it's better if we move to Murilo's presentation, and then we open for discussion about the both studies. Okay, is everyone agreeing?
Yes, I think it's better. Great talk, Dr. Sebastien.
Thank you.
Okay, so Murilo.
Okay. Thank you, Rafa. Thank you, Dr. Sebastien, for your time, for your presentation. Congratulations for the work. Very nice paper. I'm going to talk in English because then Dr. Sebastien can understand a little bit. So sorry about the English, but let's try to move on like this. Let's try to. Okay. Consegue ver?
Mm-hmm.
Okay, so this is a paper that we published on our journal. It's Revista Coluna here from our society, and it was a review of the literature, a thematic review of the literature about the sublaminar bends in the idiopathic adolescent population. It was supported by the Brazilian Spine Society that made a task force for doing some systematic reviews, and this is one of these. So we all know, and Dr. Sebastien comment about the evolution of spine implants in the treatment of idiopathic scoliosis, and we know that nowadays pedicular screws are the gold standard and the main instrumentation used for this kind of treatment. And although we had some discussions and some concerns about its safety in the beginning of its usage in the thoracic spine, mainly in deformity cases, we now have plenty of papers and literature showing that it's very safe and that it's a very, very safe instrumentation, even in the thoracic spine, even in deformity cases. But although it's very safe and it had been proven that it's very safe, we now have some concerns about the hypokyphosing effect that it has on the thoracic spine and how it drives the cervical lordosis after its treatment, mainly with the usage of all pedicular screws with high density implants and with the DVR maneuver, with the direct vertebral derotation maneuver. In the beginning of the 2000s, Dr. Mazda introduced in Paris the idea of the universal clamp, that was the band, a sublaminar band that was similar to loop wiring, and it's a malleable polyester band that with a broader surface, so it's more difficult to fracture the lamina when you are doing the translation. And the correction is a little bit different, as Dr. Sebastien commented. It's more a posterior medial translation than a cantilever maneuver of correction. The objective of the study was to review the use of sublaminar bands in the treatment of adolescent idiopathic scoliosis, mainly about the correction rates in the sagittal and coronal plane, the loss of correction and episodarthrosis rates, the safety of the bands, the complication rate, the infection rate, the bleeding volume and surgical time, and a little bit of cervical alignment with the use of this treatment. We realized a schematic review of the literature using the Prisma orientation, and we included only articles in English from 2010 to February 2019. We started with articles from 2010 because maybe some, some differences in the technical skills were a little bit different, so we started with papers from 2010. We exclude articles with animals and cadaver studies, technical notes, other articles, not original articles, reviews, and etc. Some theses that were incomplete, and other populations that are not AIS. Our search was done in the Medline, Scopus, and using Google Scholar, and we did also a cross-reference search looking for some references that could show some article that was important to the paper. Our search strategy was that we can see here in the slide. And this is our result. So with the search strategy, we found 158 articles in the initial search. And then in the end, we finished with 14 articles that were selected. Mainly the articles were excluded because it was not related to sublaminar bands or the treatment of AIS. So here are the 14 articles. 12 articles were only using sublaminar bands in the thoracic spine, and 2 articles were using sublaminar bands with pedicular screws in thoracic spine, so doing a kind of different correction than posterior medial translation that Dr. Sebastien commented on his presentation. 2 studies used the same population, so we consider them the same cohort of patients. And then we had a total of 1,030 patients with 981 with only sublaminar bands in thoracic spine with this posterior medial translation. About the coronal correction, we had a 70% rate of coronal correction that was quite similar to the results that other studies had showed with using other techniques as pedicular screws and a little bit higher than Dr. Sebastien showed in his paper. About the sagittal correction, we had a median of 5.9 degrees of sagittal correction, means 5.9, so almost 6 degrees of mean correction, and it wasn't possible to divide the population about if we had hypokyphosis or hyperkyphosis or normal kyphosis. So the whole group had a mean of 5.9 degrees of sagittal correction. And about the cervical alignment, 2 studies discussed this topic with 78 patients in these 2 studies. And the mean correction of the cervical lordosis in these 2 studies was 10 degrees mean with medium. So when we compare these results with our results, we have a publication here of our service with pedicular screws in high density pedicular screws in the thoracic spine, not only thoracic spine, but thoracic and lumbar spine. And these results are quite similar to the literature and quite similar to the results that we had in this review. So in our population here in our center, we have a mean of 60.7 coronal correction with pedicular screws. A sagittal correction here, we had 16 degrees of increase of thoracic kyphosis, but only in 2 cases with hypokyphosis. And with patients with normal kyphosis, we had only 2 degrees of improvement of kyphosis. In patients with hyperkyphosis, we had a decrease of 10 degrees. So these results are quite similar with the results that we have in the literature. But about the cervical alignment, in our series with only pedicular screws, we didn't see any case of improvement of cervical lordosis, and we had in the end a little bit of loss of cervical alignment with increase of sagittal SVA, showing that pedicular constructs sometimes don't improve the cervical alignment and can even worse the cervical alignment in some cases. About loss of correction, in this review, we analyzed 11 studies with a total of 504 patients, and the mean loss was only 1.49 degrees, so it was a little bit less than what Dr. Sebastien showed in his paper. And about blood loss, we had a medium of 682 millimeters of blood loss with a surgical time of 228 minutes. That was like very average of this kind of surgery. And our rate of infection was around 4.1 infection rate when we have analyzed all these 777 patients that were included with this analysis. There were no cases of neurologic deficit, showing that it's very safe with no cases of neurologic deficits in this series of studies. And all the studies that reported about pseudarthrosis, none of them reported any case of pseudarthrosis with a follow-up of 2 years. Intraoperative complications were around 4.7 average, and postoperative complications were around 4.5 without cases of postoperative infection. So with this review, we can conclude that the sublaminar band is safe and allows good correction in the coronal and sagittal plane. And the mean surgical time, blood loss, and complications are average and comparable with other constructions used in the treatment of IAS. So that was what I had to present. Let's try to.
Great job, Murilo.
Tá vendo a tela aí, não?
We are seeing you.
Okay, better. So that's...
No, not better, not better.
Not better. Okay. We had some questions here.
Yeah. Should we open to the people to make the questions, or we do it?
I think I can do it.
I have a question. Hi. Murilo, consegue me escutar, não?
Estou te ouvindo, Carlos.
Dr. Sebastien, thank you very much. I have a question about the technique used for the screw placement, because we know there are a lot of different instruments and screw systems, and we can perform posterior medial translation with a screw too. There are some brands which is possible to perform posterior medial translations with the screw. And I want to know if in your compare, when you compare screws with sublaminar bands, are you comparing just the implant or the technique used to perform the corrections?
Yeah, so thank you for this question. It's a very, very, very good question, because obviously we're not comparing screws and bends. We're comparing two different techniques of reduction. And you're totally right that you can do posterior medial translation with screws. It's now very common in the different brands are going towards that, because probably that cantilever is not the best technique to use with the screws, and we're not, you're right, we're not comparing the bends with the screws. We're comparing the posterior medial translation with the bends to the cantilever with the screws. And I think that the main message, or the take-home message, is that in order to give back a good kyphosis, it's probably better to use the posterior medial translation than the cantilever. But it's difficult to say more about that. Meaning, is it better to use the posterior medial translation with the screws or with the sublaminar bands? The study cannot answer this question.
Thank you. Thank you very much.
May I give my opinion about that? I suppose, I'm not sure, but it's a question. When you consider in this study the case from HSS, probably you have considered cases from Han Joachim and Matthew McKenna, right? Am I right? Yeah,
there was Joachim, yeah. Matthew Cunningham, and the PIDs, John Blanco and okay. Roger Widman.
Yes, I stayed at HSS with Hanjo, and I stayed with Matthew and some surgery. In my mind, and maybe helping to answer to Carlos, I think the problem is not, of course, the device, not sublaminar band versus the screw, but this technique. Because, for example, Hanjo, he uses the posterior medial translation with the screw, with Zimmer screws, but after he used to derotate the curves. And in my mind, the problem is when you derotate, it's more difficult to keep a nice sagittal alignment. I think, and in one of your last slides, then you say that you need to choose between coronal correction and sagittal correction.
And maybe transversal as well.
In my personal mind, I think it's more important that you choose between the derotation and the sagittal alignment. And because I think that the sublaminar band, I don't have a huge experience as you guys in France, but I have some cases. And I can see that the sublaminar band is less powerful to derotate. But in my mind, this is the most important to keep the sagittal alignment better. I don't know if you agree or if you have some argument against my point?
Yeah, no, you're right. It's I think it's a Japanese team who has published the data about the lordotic effect of the pedicule screws. It's Watanabe, and he was pointing out that the derotation maneuvers were increasing the lordotic effect of the screws, and it's probably true because once again Kevin Mazda in Paris used to say that the bends are meant to pull the spine, whereas the screws are meant to push the spine. And I think he was right. In terms of derotation, it's clear that you cannot do much with the bends. The Paris team once again has published data about a three-dimensional analysis of these patients post-operatively, and they found up to 50%, I think, derotation with the bends, but it's difficult to have a derotation when you're attached to the midline of the vertebra. You know, you cannot really have an action on the transversal plane, but it's not the main objective. And in terms of the derotation is just here, and maybe I'm not maybe I'm wrong, but in my mind the derotation is just here for the cosmetic results, to decrease the rib hump, but it doesn't really help to have a good deformity correction in the coronal or sagittal plane. And if you have to choose, I think it's better for the patient, I mean for the future of the patient, it's better to choose the sagittal and coronal. If you have to pick two, it's probably better to choose this one instead of derotation.
Indeed, in my personal opinion. Murillo, do you want to add some comments?
Yeah, I totally agree. When Sebastien was presenting the slide with coronal and sagittal and to choose, I was thinking about maybe axial and sagittal is more difficult to make them together, but very nice presentation. I think maybe one of the points that we can like try to improve this kind of correction with the screws when we have a hypokyphosis is trying not to derotate a lot, but when you are in the field, it's very difficult to calm down and try not to derotate. We like to see the vertebrae aligned, but then the profile is not that good as we would like to have. So I think that's very important. And another thing, Sebastien, about your paper, did you look at the cervical alignment of the patients and compare them? And what about because in my opinion, it's the cervical alignment is the answer if you are doing a good job in the thoracic spine about the sagittal profile or not. So if you're doing, it's going to improve. You're not doing, it's going to worsen. And in some cases, we've seen some patients getting worse in the cervical alignment. And what about the rods? I've read your paper and I've noticed that you use it 5.5 titanium rods in it. And people in HSS use the 6.0 cobalt chrome rods. So they had a rod much more stiffer, and even though they had like not so good sagittal profile, but very good coronal profile. May you comment on the rod too?
Yeah, so for the first question about cervical alignment, we didn't look in details in this particular study, but that's a thing that we've explored a little bit before I went to New York. It's very I don't know the word in English, intuitive to think that when you will improve, as the curves are proportional between each other, as you will improve the thoracic kyphosis, you will necessarily improve the cervical curvature and give back a cervical lordosis. we explored that on a little series of our patients. It's the paper I think you included in your meta-analysis about the T1 slope in AAS patients, and we found that when you have an increase, the T1 slope, so that reflects, it's something that is related to the shape of the thoracic spine. So the T1 slope was correlated significantly to the cervical lordosis. So if you have postoperatively an increase of the thoracic slope, meaning that the T1 is a little bit more tilted in forward direction, you will have an increase of cervical lordosis. So it's not something that we compared between the screws and the bends, but it's very likely that increasing your thoracic kyphosis will help you to give a better cervical profile. But once again, it's not very clear if the cervical kyphosis is, in the short term, it's not very clear if it has an impact on the quality of life of the patients. But it's the thing that is difficult with IAS patients is that they are not really complaining except for cosmetic, but they are not very complaining about pain, and it's something that will probably come after. In terms of Rhodes material, you're totally right, and the patients that were included in this study have been operated on between 2010 and 2015, and since for two or 3 years now, we're using more and more stiffer rods and a 6.0 cobalt chromium rods, because the thing that we noticed is that the bends are very powerful, and when you tension them at the beginning, you see the spine and the vertebrae being pulled backward and towards the rod. But at the point when the tension is too great, it's the rod that begins to go to the spine. So at the beginning, you pull the spine, and then the rod is being bent toward the spine. So it's quite usual when you use a 5.5 titanium, because it's quite it's not very stiff. But it's you see this phenomenon a little bit less when you use stiffer rods. So maybe if we would do the comparison with the patient that we are operating on now, we won't have such differences in terms of coronal correction. It's probably due, it's multifactorial. It's not only the bends, it's not only the technique, it's probably as well the rods material, and there are a lot of things to take into account in order to understand the differences between these two implants.
Totally agree. Thank you. And you mentioned about the quality of life of the patients with AIS. In this paper that we presented with all pedicular screws, and the patients who improved the cervical alignment and who didn't improve it, they had the same quality of life measurement. So it's very difficult to measure quality of life in patients with AIS because they are very good. So it's like you said.
And they are adolescents. So it makes it much more difficult. Yes. But that's all the point of these patients. Sometimes they don't understand why we say that they need a surgery, because they feel good. Sometimes they are not very impaired with the deformity and with the cosmetic, and that's all the difficulty in doing surgery in these patients, is that you have to bet on the future and to bet that it will be better for them to have a correction.
Nice. I think we had a question from the audience about the crankshaft.
Yeah.
Phenomenon.
We have three questions. Do you think it's better for the Alexandre ask the question, or we can do it? Alexandre?
I think he can't, Fernando.
Yeah. Okay. He want to know if your opinion about the crankshaft phenomenon in young patients with the use of the band.
So that's a good question. The first thing is that we only use bands for definitive fusion, for final fusion. I mean, it's not, we don't use them with a growth friendly technique. So the crankshaft phenomenon is more likely to be seen in very young patients. So it's not really I mean, it's not really the problem in the patients where we use sublaminar bands, but I will keep this question maybe for after, because I have a clinical case that is a little bit related to a kind of crankshaft phenomenon, and it's very interesting. And I mean, I'm not saying that my case is very interesting, I hope so, but it's a very interesting topic, and maybe we can discuss this point after.
Okay. And what's your experience with different kinds of metals in the rods? For example, titanium, cobalt chrome, or steel. Do you have a different experience with that in the band or not?
Yeah, that's what we were discussing with Dr. Daer, is that when you use a stiffer rod, I think you will have a greater coronal correction and sagittal correction, as at a point it's not the spine that is pulled backward, but the rod that is pushed forward. I'm not sure it's very understandable, I hope, but at the point, if your rod is not stiff enough, it will bend towards the spine, and so it's probably better to use stiffer rods. And now we're using a 6.0 cobalt chromium rods.
The first question was about the using the screw. Sorry,
Fernando, just a second. Sebastien, it's Rafael again. I totally agree with you. I try to use almost ever the cobalt chrome, maybe 5.5. We don't have 6.0 rods so available here in Brazil, but I always try to use 5.5 cobalt chrome. But it's interesting that I remember, I don't know if this study was published, but I saw a presentation, and the Professor Mazda compared the cases from Paris, all the cases used operated with a cobalt chrome, with the cases from Professor Saldegozzi from Toulouse. Mm-hmm. That he used the titanium. So he compared the cases with cobalt chrome from Paris with cases from Toulouse with from titanium, and the results was not different, surprisingly, because I agree with you that in my mind, as more stiff rods, better the correction. Do you know about this study? Are you familiar with this study?
Yeah, I do. I think the results were that the results in the coronal plane were the same with both materials, cobalt chrome or titanium, but the cobalt chrome provided better sagittal correction. So I think it's possible to use the both rod materials. It's not bad to use titanium, but at a point you will not be able to it will not allow you to go further in your correction. If the spine is too much stiff, or you will not be able to pull as much as you want. So you can use it. It's good. You'll have good correction. And once again in the paper we published with a comparison of the HSS patients, it was a 5.5 titanium rods, and the results were not bad. But I think cobalt chromium is probably stiffer and probably better. So I don't know if stiffer is better. It's another question that is currently discussed in the literature, because some authors advocate for stiffer materials to be responsible for more PGKs or whatever. But if you aim for the better correction, you should choose the stiffer rod.
Okay, thank you. Fernando?
I think that's it. The first question was about also about the rods and the power, how strong it is to correct the kyphosis. I think it's nothing to do with the bend.
I thought it was Nelson. Sebastien, one of our colleagues from Brazil is asking about in your study about the screw group, which material was used, and he said that in cobalt chrome rods, even with screws, you can do the pull the spine, and as we are talking, as the cases included in the screw group was Hanjo's and Matthew's case, probably because they use a lot of cobalt chrome. I've never seen those guys using titanium for scoliosis in HSS. Is correct?
Yeah, they were all cobalt chromium in the HSS patients.
Yes, that's it.
But once again, it's not that simple to understand what parameters are influencing the correction. There are probably a lot of them. The technique of correction, rods material, implants or anchors to the spine. There are a lot of parameters. And obviously you can do posterior medial translation with screws using a 6.0 cobalt chromium rods, and you will have probably good results as well. But anyway, with the bends, I think that maybe the connection to the spine being a little bit less stiff, you will have a better correction. It will allow for a better correction.
Okay. So let's move to the next section. Any other question? No? Sebastien, can we move?
Sure.
Okay, let's start with your case. You have one or two cases or more?
I have at least two.
Two cases.
I have two, but I have a third one that is a little bit short. But if we have time, maybe we could discuss it.
It's up to you. I'm concerned about the time in France. But
no, it's fine. I'm at the hospital. I'm free. No problem.
Okay, let's go.
So it's fine. Do you see my screen? Do you see the presentation?
Yes.
Okay.
Yes.
Perfect. So okay, so the first case, it's the case of an 18-year-old girl with a Lanky 5 scoliosis. So she has a curve that is located in the thoracolumbar area. The apex is located at the T12 L1 disc, and the curb angle from T10 to F3 is 41 degrees with a quite coronal imbalance. The curve is flexible, as you can see on the side bending, where you have the, I don't know if you do that as well in Brazil, but in France we follow the Dubousset, the Dubousset school, who says that your instrumentation has to, I mean, your LIV should be where the disc opens on the two side bendings. So you can see there that the L2, L3 disc is opening in the concavity. So it's probably, you could probably stop there, or maybe the vertebra, or maybe L3, so L2 or L3. You can see that there is an overlying curvature in the thoracic area that is probably structural, as it doesn't change on the side bending. The cup angle is only 28 degrees. So the question here is, what fusion levels would you recommend for this patient? I don't know who wants to answer this question.
I may answer it. Like, in my opinion, this is a 5C. So, and the trunk is decompensated for the left. So it's, in my opinion, I can't see the clinical photos, but like, if the patient doesn't have a hip hump important, I would think about doing only a selective lumbar fusion, and then I should go cob to cob. Maybe 1, 2. Maybe
so from T10 to L3.
Yes, 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 more or less like this. Yes.
Okay. There are other strategies. You're right. In this kind of curves where the thoracic component is not it's not that much, you can probably just do a selective fusion. I totally agree with you. And if I only had this picture, I would do something like T10 L3. I think it's fine.
I think the important is, when you go to a lumbar selective fusion, it's very important to know that the thoracic spine won't improve automatically, spontaneously, as the lumbar spine sometimes does with a thoracic fusion, so a thoracic selective fusion. So I think it's very important to see the patient, to look at the patient and see if the patient has a hip hump, and if this hip hump is not important. So, but in this case, I suppose it's not important because the rotation of the vertebrae
is quite low.
Small.
Yeah.
Yeah. So I would think about a selective lumbar fusion.
Okay, so obviously it was a trap, as you can suppose.
I imagine something's going to be wrong, but okay.
Okay, so if you look at the sagittal profile, you can see that there is a kind of a problem there. So the T4, T12 kyphosis is actually a lordosis of 15 degrees. The L1S1 lordosis is only 25 for a PI of 40. So you could expect in this patient that the lordosis would have been, let's say, between 30 and 50. And there is a thoracolumbar kyphosis of 12 degrees that corresponds to the apex of the scoliosis. So
Sebastien, it is a type 2 of the sagittal idiopathic scoliosis classification of Kalimann-Roussoli, right?
Yeah, that's it, with a thoracolumbar kyphosis. Yeah.
Yes.
I think it's 2B, with the lumbar kyphosis. But my question would be like to you, Sebastien. Do you take into account in your workflow this classification that Pratali mentioned? And if you do, how do you pick your sagittal vertebra, the LIV vertebra? Do you look at the sagittal profile to pick your LIV vertebra, or you don't take this into account?
We don't use it in a daily practice because it's quite difficult to use it. So I mean, it's quite difficult there's a lot of types, and I'm not sure there is a big impact on the choice of fusion levels. But the thing that we look for the choice of LIV is more the coronal view, the frontal view, and the choice of the UIV is more a balance between the coronal and the sagittal view. But for the choice of the LIV, we only, I mean, except in some very particular cases like the thoracolumbar kyphosis associated with a thoracic curve in the coronal plane. But in the other cases, in most of the cases, we only look on the coronal for the choice of the LIV. But in this case, the thing that will change with the sagittal profile is the choice of the UIV there, because if you go from cub to cub, as you mentioned, that is that would have been a good strategy if you didn't have this profile. But in this case, I'm not sure that going from T10 to L3 will give you a satisfying result at the end.
Actually, with this X-ray, you have to consider that the thoracic spine is pathologic. So
sure,
it can be compensating, but it's not normal. So I agree.
Yeah. So we did a T3L3 posterior fusion with a hybrid technique, and as you can see, the screws aimed to correct the main curve, so the thoracolumbar curve or the upper lumbar curve, and the bends were there to correct a little bit in the coronal plane, but once again, it was not the goal, and the goal was to restore a proper thoracic kyphosis. And as you can see, we had a 35-degree gain of kyphosis in this case because it was quite flexible. But the result is not bad. Is not bad here. So just a little bit of discussion. So the sublaminar bends are very powerful tools for kyphosis restoration, and they should be used for that. You should be aware of the preoperative sagittal profile, even in Lanky 5 patients, because as you said, you can have a pathological thoracic spine over lumbar curvatures. And the 3D deformity implies a 3D correction, but as we discussed before, at least a 2D dimension, correction.
Nice case. And what about your surgical strategy in this case? Because you had to correct the lumbar spine. Do you start correcting the lumbar curve with compression in the convex side, or how your surgical workflow in this particular case?
So basically, what we do when we do correct patients with these kind of curves or with double curves, so Lanky 3 or Lanky 6, we put first the rod into the screws. Then we do rod derotation maneuvers in order to do a first correction of the lumbar area. Then we connect the two rods to the upper anchors, to the upper thoracic spine generally with hooks. And once everything is set, we do compression distraction maneuvers in the lumbar area. And then we put the two transverse connectors. And once we have that, we have our rigid frame in the thoracic area. And at this point, so at the end of the correction, we do the tensioning of the bends. But the first maneuver is the rod derotation in order to correct the correct the lumbar area.
Nice. I think maybe you should move on to the next case.
So should I do the second case now, or do we move to?
Yes.
Okay.
Just one question. While you open the second case, one question from the audience about the posterior column osteotomies, like Smith-Peterson and Ponte. Do you frequently do for? Do you think it improve your sagittal correction, the posterior column osteotomies, or what do you think about?
Well, usually we don't do posterior column osteotomies except in very particular cases. Usually patients with AS are quite flexible, so you don't really need to do osteotomies except in the sometimes in the lumbar area. The thing that might help us to better correct the sagittal plane is the opening of the ligamentum flavum, because as you put implants into the canal, you have to open it. We just do like a 1 or 1.5 centimeter wide opening of the ligamentum flavum, but it may help to lengthen the posterior column and then to increase kyphosis. I don't know what's your experience with that. You guys in Brazil, do you are you very used to do osteotomies in AS patients, or because I mean in Marseille it's more something that we keep for stiffer patients like ASD or things like that, or Schauerman if you want to decrease the kyphosis. But what's your opinion?
I used it to do more, and nowadays I'm not using so much. I agree that especially to take off the ligamentum flavum, it helps a lot for restore the sagittal alignment. When you're opening a case with a very hypokyphosis in thoracic, you take off the lamina, you can touch the flavum ligament, and you see it's very hard. Mm-hmm. And I really agree that if you take off especially the ligament, the flavum ligament, more than the facet, will help you a lot to restore the sagittal alignment. But I use it to do more than I'm doing now. Mm-hmm. I don't know the other guys.
The same.
Yeah, but I think one problem here in Brazil is because we normally a lot of times we don't treat the scoliosis in the right time. We need to treat the scoliosis after the right time. And so a lot of times we treat more stiff curves than we need to treat the stiff curve because of the time of the treatment.
Yeah, that's obviously a factor that will I mean, when you say that you operate them a little bit after the time you should do it, it's like what age, 25 or 30, 35? Do you have at what, I mean, what's the kind of cutoff of patients being too much stiff that they will need an osteotomy?
For example, here last year, we from Brazilian Spine Surgery Group, we performed a task force to treat scoliosis as a philanthropy in Portugal. We performed 24 surgeries in only 4 days, And in my city, I live in Recife. Recife is in the northeast from Brazil,
Yeah.
In the coast. In my city, we have more than 300 kids waiting in the line for scoliosis surgery, just in my city. And now the Brazilian Spine Society is performing a paper, a work, a task force to know the number of the kids, because we don't we even don't know the right number of how many kids are in the line waiting surgery. And so it's normally we perform surgeries in 18, 19 years old, when that girls or boys was the scoliosis was noted about 11, 12 years old. And so there are a delay about more than 8, 10, a lot of years. So this is different in Brazil. It's different. We can perform surgery in the right time.
Yeah, that's a big concern, because you have a curve worsening and probably some lumbar curves becoming structural, whereas if you would have operated them before, you wouldn't have fused the lumbar area or things like that. You're right. So should we move to the next case?
Yes, please.
Okay, so the second case that I've prepared, it's a boy of 15 years old. He has a Lanky 4 curvature, or maybe it's a 3, with two main curvatures, one in the thoracic area of 56 degrees and one in the lumbar area of 43 degrees. And the upper thoracic spine is deformed as well, with a rotation and a curve of 34 degrees. It's quite well aligned, or the global alignment is not that bad, with a CVA at 0. So the head is remaining over the pelvis. And in lateral, you have a cervical kyphosis of 28 degrees, a T4, T12 thoracic kyphosis of 5 degrees, and a lumbar lordosis of 64 degrees, not related to the pelvic incidence of 84 degrees. So a little bit of loss of lordosis. So at this time, we did a lot of surgeries in Southeast Asia, where hospitals didn't have that much money to provide us with the implants. And we noticed that it was not really necessary to put a lot of bends in order to have a good correction. So we said, okay, why not? Let's do that. Let's put only 3 bends at the apex of the deformity. So you can see here the screws in the lumbar area for the correction of the lumbar curve, the hooks at the top, and just 3 instrumented vertebrae at the apex of the thoracic kyphosis, of the thoracic curve, sorry. You can see that the correction is not that bad, with a 68% correction of the thoracic spine, 70% of the correction of the lumbar spine, and T4, T12 at 20 degrees, so a 15-degree increase of the thoracic kyphosis, and a restoration, not entirely, but a restoration of the lumbar lordosis. So the result is quite good, with a few number of bends. But the things are getting a little bit worse. At 2-year follow-up, you can see that we had a very bad maintenance of the correction, with an increase of the thoracic curve by 18 degrees and an increase of the lumbar curve by 17 degrees, with maintenance of the sagittal profile restoration. So here you can see the evolution. It's kind of a crankshaft phenomenon that we had here, because as you can see at the 1 year follow-up, you can see that we have the impression that the rods are on the side of the spine. It's not totally that, because the rods are still attached to the upper thoracic spine, but the spine has rotated a little bit with a worsening of the curves, and so it's a little bit like a crankshaft phenomenon that we discussed earlier. And you can see that once the curves have worsened between first erect and 1 year, it's stable at the end. At 2 year follow-up, there's not any more changes. So it's not a question of pseudarthrosis, it's just a problem of maintenance of correction while the fusion is being acquired. So you don't need a large number of bends in order to have a good curve correction, because as you can see, with just 3 bends at the apex of the curvature, it's where the vertebrae are farther from the rods. You can tension the bends, and with only 3 levels, you can have a good correction of 68% or 70%. It was discussed by the Toulouse team that we mentioned earlier. They published the results in last year, and they found that they compared patients with a low number of bends versus high number of bends, but actually they had patients with 4 or 5 bends and patients with 6 or more, and they found no difference at 2 year follow-up. But I believe that with our experience, we found that even if a low number of bends is sufficient to have a good correction at first erect, you have to be aware that it's probably not strong enough for maintenance of the correction while fusion is being acquired. So during the 3 or 6 first months, it's probably not strong enough. So you can decrease the number of bends, but beware of not decreasing them too much, or you will have a loss of correction. Do you have comments about that? I put back the pictures, the X-rays.
Very, very illustrative. I always say everyone who presents a not so good case, I give congratulations for that. But it's very important for teach who is starting to use techniques, and I think it's perfect. About the crankshaft, I would like to listen your opinion, because nowadays, Sebastien, I'm using more hybrid construction. I'm still using bands in the concave sides for correct using the translation, and I started to put some screws in the convex, not to pull the spine, but try to derotate, a gentle derotation. And in my mind, maybe those screws in the convex side may be a solution for when you have to, if some reason you need to operate a young 10 years old boy or girl. Maybe if you have the concern about the crankshaft, put some screws in the convex side. What do you think about that?
I think it's all about. I think the crankshaft phenomenon is probably all about the stiffness. Yeah, early onset, or even sometimes this one had a 15-year-old. It's not really a crankshaft phenomenon, but it's anyway. I think the main concern with that is the stiffness of the connection between the rod and the implants, and the anchors to the spine. And with the screws, you have it's very stiff. The connection between the screws and the rods is very stiff, and the vertebra will not move with regards to the rods. And so maybe you're right. If you want to avoid having a crankshaft phenomenon, you need to have screws either in the convex side or at least at the top of your construct, because in this case, I think if we had screws at the top and not hooks, they won't have slipped to the concave side of the proximal thoracic curve, as you can see there, and I think we wouldn't have had this problem. So it's quite complex, but it's a thing that we don't see much when we put much more bands. I mean, bands at more levels. So it's probably also a concern about the maintenance of the main curve correction. You know, probably the whole spine has rotated in this case.
Sebastien, in this case, in those other one, you use only the rooks in the top of in the proximal part of the orthodesis. Normally, you perform when you use sublaminar bands, use only rooks, or you today use more screws?
We originally we used only hooks at the top, you know, by putting like a claw on the two UIV, and with compression of the hooks, you have a very strong fixation to the spine, but this fixation does not is not very stable in the transverse plane. You know, it can slip on the concave side. So now we're using more and more screws at the top, especially in patients with upper thoracic curves. So when the upper thoracic curve is structural, we use screws in order to be able to control it, and maybe to do some a little bit of distraction or compression, and in order to avoid this kind of phenomenon. And it's probably also better in order to restore a proper shoulder balance.
Okay, thank you.
I think, Sebastien, you mentioned that you had a third case, so if you want to show your third case.
Yeah, okay, sure. I don't want to have all the to keep all the time for me. But the third one is quite quick. It's just to well, it's this one. Okay. Okay, so let's move to something else than AAS. This one is Marfan Syndrome. He's 13 actually, not 14. I mean, he was 13 at this time. So he presented with this triple curve. With a upper thoracic spine at 43 degrees and two major curves. I mean, the major one was the thoracic one, but the main problem in this patient was the sagittal profile. As you can see, there is a cervical kyphosis with a 20-degree, it's lordosis, not kyphosis, 20-degree lordosis in the thoracic spine, and a 32-degree lordosis in the lumbar spine, with a thoracolumbar kyphosis once again. So in this patient, we did the same kind of correction. Excuse me, just wait a minute, it's not the right version. Sorry for that. Okay, this one's better. So we did a T2L4 posterior fusion, and as you can see, there was a satisfying coronal correction in this patient, except for the proximal imbalance. As you can see, there's quite a shoulder imbalance, but more importantly, you can see that the thoracic kyphosis was restored as well, with a plus 31 degree increase of the kyphosis and an increase of the lordosis as well. So just for the little story, and you will say once again that I only show my bad cases, but I think it's more interesting to show the bad cases than the good ones, because no one cares about the good ones except the patients. It's quite important, but I think it's important to show the bad cases. So the problem in this patient is that the proximal imbalance was worsening, as once again we didn't have a good it's a little bit the same one that the previous one, except that this one, being a Marfan syndrome, it was much more flexible, and the proximal imbalance did worsen. So I did a revision surgery at 15 months, and as you can see, we released the bands as this part of the spine was fused. We believe that it was not necessary to keep the bands, and once the band was passed first time 15 months earlier, it's quite difficult to put new ones. But anyway, we didn't choose this option, and we put screws at the top, and you can see that with a more rigid fixation at the top, we were able to restore the proximal alignment of the spine. So I think the conclusion for this one could be that if you have a proximal imbalance, you should maybe not hesitate too much longer to go to revision surgery, even if it's sometimes difficult, because patients are often not very happy with this kind of imbalance. I don't know. What's your opinion? I don't know if you because usually, I mean, when I presented this case to the surgical staff of my department before surgery, they all said that it was like crazy to do a revision surgery at this time, because everything would be fused, and I will not obtain a good correction. And finally, probably because it's a Marfan, the correction was not that bad, and the patient was very satisfied with the correction. Do you have any? Yeah.
Very difficult case, I think. This case is very difficult. The sagittal plane is completely crazy, yeah. Very difficult. But yeah, completely very difficult. And I think that Marfan is a very good case for the bands, because sometimes the pedicles are very dystrophic and you don't have nowhere to put your screws. So with the bands, you have somewhere to anchorage your fixation points. But my question is about the proximal fixation. Two cases that you showed, I think you had problems because of this claw without any screw adjacent to it, or without any band adjacent to it. Or what do you think are proximal fixation strategy nowadays? You're continuing using the claw, or you may use this particular claw that Implanet has, the Jazz claw, that's very stiff too, or you should put some screws in conjunction with this. In the regular cases, what's your proximal fixation strategy in a regular case?
In regular cases where when your UIV is stable, meaning there's no rotation, there's no a structural curve where your proximal anchors are, you can use this kind of fixation because it's strong enough to do the correction that you need. But the real problem with this fixation is in this kind of patients where the upper thoracic spine is rotated and is a structural curve. And you're totally right. I totally agree with you that in these cases, you should use a more stiff device for the proximal anchors. And you can use the hooks, but if you do, you should have either sublaminar bands very close to the hooks or pedicle screws. But you should have probably the problem in this patient that we would not that the evolution would have been different if we didn't do that. The problem here is that the hooks are not strong enough to maintain I mean, not to maintain, but to give a satisfying correction of the upper thoracic spine. It's a technical problem. I mean, it's a problem of strategy, and we should have used screws instead.
Okay. And in the revision, did you perform any like osteotomy or only go a little bit higher with screws?
No, we just went one level above. So it was T2 and we went to T1. And as it's, I think it's because it's a Marfan, we were able to do a little bit of compression and distraction maneuvers once the screws were inserted. And it was sufficient to have a good balance of the upper thoracic spine. But it would probably not have been the same in an IAS patient with normal bone because this area would have been totally fused and it's very less likely that we would have been able to correct just by going one level above.
Thank you.
Okay, so I'm done with my cases, unless there are some questions about them.
Any question? I have two cases to present. Is anyone have a question to the Sebastien cases? Is it okay for you to stay a little bit more to maybe comment the case that I'll present, Sebastien?
Sure, of course.
Okay, so I think I'll move. Can you guys see my screen?
Yes.
Okay, so I'll present two cases. Actually, I decided to present cases different from adolescent idiopathic to show the solution of the sublaminar band. Those two cases I operated in a city here in Brazil, in Aracaju, with a good friend, Dr. Diego Benoni, and it's different than it's not idiopathic scoliosis. So the first case is a 15-year-old lady with a cerebral palsy. She was non-ambulatory, dependent of the wheelchair, and she presented a progressive spine deformity. As Carlos Romero said, this case, this city is Aracaju is very close to where Carlos lives, and is one of the good examples of we were operating not in a perfect time. So as you can see, the more than 100 degrees angle, and with also a pelvic obliquity. Here's the CAT scan. And here, the big concern of those cases that the pedicles are very thin, very dystrophic, very dysplastic. And I totally agree that you can use screws. It's not impossible. Many surgeons do cases like this using screws. But I prefer to use a different technique. I use a technique of 4 rods and dominoes. I put screws from the bottom and from the top and the bottom, from T3 to T10, and from L3 to the pelvis. And I put 2 rods on the bottom, 2 rods on the top, and I corrected using the cantilever with the dominoes, and put 2 sublaminar bands, more to fixate than also to correct something. And in those cases, I did Smith-Peterson's at the apex. I did 3 or 4 Smith-Peterson's at the apex. So here's the correction. And in my mind, the biggest value of this technique is that you don't stress, you don't need to put force in the apex, whereas the pedicles are the worst, and you can have a good correction, a very well aligned spine. And it is. Any comment about this case, or are you familiar with this technique? Actually, I learned this technique with Hanjo Kim in HSF. He said that Professor Boashi used it to do many cases like this, not with so many screws, but Hanjo is still doing with 4 rods technique for the cerebral palsy cases. Are you familiar, Sebastien?
No, I'm not. But it's congratulations on this one. It's a very impressive correction with a good restoration of the pelvic obliquity. That's the more important in these patients. That's impressive. The thing that could be useful in this kind of cases is like the bends can help you to align the upper. It's basically the thing that you did, I think, but can help you align the upper spine and the lower spine. Like you can put you can gradually tension your bends, or maybe that's what you did in order to progressively pull the spine towards the rods, and then helping you to put your rods into the screws. Did you do this, or did you just tension the bends at the end in order to protect the apex?
No, actually, we made the tension of the bend at the end after the correction. The correction was mainly by cantilever, joining the 4 rods using dominoes, and then after we put the band more to fixate, to stabilize the apex where it's too much strained, and then we could see the final correction, a little bit more correction.
Because that's something that sometimes we use in our patients, like when it's difficult to when we feel that we need too much force in order to put the rods in the hooks or in the screws. You can tension your bends a little bit earlier than you would do usually, and it helps you to lower the rod. I don't know if I make myself clear. Like it helps you to correct the spine, and you need less force and less constraints on the screws to insert the rod. Can be useful. But this one is very impressive. It's quite challenging to perform surgeries with such deformities.
Mm-hmm. Okay. Any other question? Can I move on?
Yeah. Rafael, if I may, excuse me. I was just thinking when you were presenting your case in our department. Maybe it's better at that. In our department, we like 10 or 15 years ago, we used to manage these patients with the Luque Galveston instrumentation. You know, the unit rod that goes into the iliac wings, and with sublaminar wires, steel wires. Do you have any experience with that? So what do you think of this kind of technique? Because it's a little bit, I mean, here you put screws, but you could have done the same with only bends if you didn't succeed in putting the pedicle screws.
You mean put the rod in the iliac?
Yeah, it's the technique that was described. Yeah, it's like a very special rod. It's a U-shaped rod. It's only one rod that does the two sides, convex and concave. And at the distal end, it's like the S2 LR screws that goes, but it's connected to the rod and it goes straight. It's quite the same the same one. It's just in the LR LR wings. But anyway, yes. Except that the rest of the spine is instrumented with sublaminar wires, and you put the spine to the rod is a little bit easier in this kind of patients.
I know what you are saying. Murilo and I, we did our spine fellowship in a hospital here in São Paulo. There is a hospital dedicated to treat syndromic kids and neurological deformities. In the past, our former professor used to do many cases like this, but nowadays I'm not seeing any more. I don't know who is still doing cases like this. Do you think is still doing in France or also was in the past?
No, we do manage this kind of patients now with either all pedicle screw instrumentations or hybrid instrumentations, but it was like 15 years ago, but we stopped.
Yeah,
we stopped not doing that.
Yes. Okay, and the second case, the last case, is a 12 years old lady. She had a diagnosis of type 1 neurofibromatosis, also with a progressive spinal deformity. She had no neurological complaint or deficit, it's only deformity. And neurofibromatosis also has a very particular deformity. We can see here, very short, angular, sharp curve, almost 80 degrees in 5 vertebrae, and also hyperkyphotic deformity in the lateral view. Not so rigid for luck, kind of flexible, and we could see the vertebral dysplasia and also a lateral subluxation of the T9 to 10 and T10 to 11. That was something that concerned us. And also, if you apply the new concept of the deformity angular ratio that was presented by Wang, Lanky, and all, that you need to calculate the cob divided for the number of vertebrae. So in this case, the coronal DAR was 16, and the sagittal was 10, and the total DAR was 26. And in the study published by Wang and Lanky et al., they say that in cases where the total DAR was higher than 25, there was a significantly high risk for spinal cord monitoring events. And also we can see the pedicle dysplasia, especially here. You can see very thin pedicle, and the close relationship between the spinal cord and this thin pedicle. So again, you can use screws. You can perfectly do this deformity with a full screw construction, but we decided to do a hybrid construction with screws on the top. We put 5 bands in the in the concave side in the 5 deformity vertebrae. In this case, as the deformity was hyperkyphotic, I decided to put screws in the concave side and they rotate. And because as we mentioned a few minutes ago, I know when you derotate, you lose kyphosis. But in this case, wasn't intentional. We would like to correct the hyperkyphotic, and then we finish it with screws on the bottom. And this is the correction. 79 to 19 degrees in coronal, not perfect, but well aligned. We could see a good correction in sagittal alignment also, and more special in the clinical view, because in this case we derotate, so we can see perfectly. We can see the improvement of the thoracic hip hub. That's it. Any comments?
Yeah, once again, it's a very nice case, and the correction is impressive. Do you use systematically neuromonitoring when you operate, maybe for neurofibromatosis, but in AAS patients, do you use it each time?
Yes, here in Brazil, it's very cultural. I suppose I can't say all surgeons, but I would say that the vast majority, almost 100% of the scoliosis cases using the monitoring, the neural cord monitoring. Don't you use in France? Yeah, we do. For a very long time, there was a neurophysiologist in the OR room with us. And now for like 5 years or something like that, we have the NIM Eclipse from Medtronic. It's a surgeon drive neuro monitoring. It's a simplified neuro monitoring, but yeah, we do. And especially in these cases of neurofibromatosis, first of all, you have the very angular deformity that is very at risk, as you said, of neuro event, and you have the neurofibromatosis itself, where the spinal cord is very sensitive. So, no, that's great. That's a great case.
Rafa, may I one comment? I think this curve, the pedicles that you put it in the convexity are very important, because you know that neurofibromatosis, they are very aggressive and sometimes they progress even though you do a posterior fusion. So I think the derotation that you made with the screws in the apex, but the fixation, the 3-column fixation that the screw provides, I think it's very important in this pathology. I think in neurofibromatosis, fixating, the more you fixate on the apex, the less the chance of Scoliosis and everything. Very nice case.
I agree. I totally agree.
Very nice.
I'm using more. I'm intending to use more and more screws in the convex side, maybe 1 or 2. In the beginning of year, Sebastien, I was to Paris. I stayed with Brice Il Rebord, and he's using more and more, almost all the pedicles put in screws, and sublaminar bands in the concave. I think maybe it's too much, but in my mind, I intend to use more and more, at least 1 screw or 2 in the convex side to improve the fixation, and try to gently do the rotate, not to push the spine, as you mentioned, because you will sacrifice the sagittal correction, but try to do a gentle the rotate.
Yeah, I mean, to my mind, the only advantage of doing that in a AAS patient is to be able to derotate, because if you just want to have a coronal and sagittal correction, you can. I mean, bands are enough to do that, to do so, but I'm not sure it's really necessary to put screws in this area, but it's maybe something that we should explore to know if it allows for better correction. But for the moment, I think the first thing to be aware of is the proximal fixation, as we discussed a little bit earlier. But I wanted to know how you. So by putting your screws, how do you manage for a correction of the thoracic area? Do you put the screws and then tension the band, and at the end connect the screw to the rod, or how do you manage the both implants?
What I do is usually I put first the left rod, okay, with the bands loose, yeah, but I connect the rods in the screws on the top, on the bottom. I don't do any correction. So I put the right rod. Then I put the cross links. I use 2 cross links that I think helps me to protect the correction, because when I in the beginning I didn't use cross links, so I could see the rod deforming, and now with those cross links, it protects me. It's similar, not exactly, but similar of the frame technique that Professor Mazda used to do. Then I do the correction tensioning the bands, and in those cases that I put screws, at the same time that I'm tensioning the band, that I'm pulling the spine, I'm asking for my assistant, usually a resident or some colleague, to gently try to derotate. I put monoaxial or uniplanar screws in the convex side, and I ask to him gently derotate, not push. Every time I say, don't push, only derotate. And I'm doing but mainly the correction is tensioning the band and pulling the spine. And then I fix all the screw sets. That's why the way that the workflow that I created. Hi.
Okay.
So, any question?